Good morning, everyone. I hope that everyone is doing okay. Welcome to today's webinar. Today we're going to be hearing from Derine Louw about, let me say, Trichotillomania. I hope I'm saying it correctly, or hair pulling disorder. This is something that I actually really don't know a lot about, so I'm very excited about today's topic. Derine is a clinical psychologist. She's currently practicing in private practice after having transitioned from the public sector where she was for over 10 years. And she actually did her PhD in this subject in cognitive training for in trichotillomania. And we'll be sharing that during the presentation as well, the PhD. So Derine, I think that's everything and you're welcome to get started.
Thank you, Tony. I am happy to be doing a webinar again. I think last time we had lots of fun. So let's see how we can share some information today. Just wanna, can you just enable my share screen?
I am doing that now. It should be on.
Okay, there we go.
Derine, before we start, I just wanted to let people know if you have any questions, you're welcome to pop them in the chat box. Derine will be talking for about 30 minutes and then we'll try to do some questions at the end. And yeah, so we'll be looking at the chat box. We'll share some links, our YouTube link as well, where the recorded version will be at. All right, I'm done. Off you go, Derine.
Perfect. Thank you, Tony. Right, so yeah, I named this talk Trichotillomania because no one really knows what it is when I tell them. And when I did my study, it was like, okay, never mind, hair pulling disorder. So that's what we'll be talking about today. So first, I always start with a quote. I just like doing that. So I want you to just take a look. This was one of my research participants. I did part of my study was qualitative as well, and I asked them about the experience of living with hair pulling disorder. And this is what the one research participant said. You go through these days where you can feel like you can deal with it. And then there are other days when you just go into almost like a dark place because you feel so disappointed in yourself that you ask yourself a question like, really, why can't you just rek yourself reg? And I think that is something that kind of, for me, just pulls together what hair pulling disorder is. It's a behavior that is extremely difficult to control and that can go, is linked to a lot of shame. So what we'll be covering today, we're going to have a look at what is hair pulling disorder, why does it occur, what is the impact thereof, and also what are the treatment options that are out there. Okay, so first of all, what is it? Okay, so a French dermatologist, Louw, coined the term trichotillomania over a century ago. And as you can see, it was derived from different words, meaning hair, pull, and mania, like being bad. So the criteria for trichotillomania or hair pulling disorder, according to the DSM, is recurrent pulling out of one's hair, resulting in hair loss, repeated attempts to decrease or stop the hair pulling, and the hair pulling causes significant clinical distress or impairment in social, occupational, or other areas of functioning. The hair pulling or hair loss is not attributable to another medical condition, and it's also not better explained by another mental disorder. Now, it's important to note that from the jump from DSM-4 to DSM-5, the inclusion criteria was relaxed quite a bit. So there are more people being included or being diagnosed with trichotillomania than before. What is interesting is that very often patients who present with hair pulling disorder, that they present with that as a secondary diagnosis. So they might come to the clinician with mood disorder or anxiety disorder, and the trichotillomania is very often secondary. So why does this happen? There are a lot of different models, as anything that we work with in psychology or psychiatry. Different theories, different models to explain, and I'm just going to quickly take you through a few highlights. So first of all, there's the ethological model that suggests hair pulling can be related to excessive grooming. Then there's the psychosocial model that says that behaviors are the outcome of stresses experienced and a response to internal and external forces. It further says that current situations carry more weight in understanding the behavior than past experiences. And at the core of hair pulling behavior is an interaction of physiological characteristics, thoughts and feelings, and consequences of the behavior itself. The model also suggests a biological vulnerability, altered pain sensitivity, behavioral triggers, reinforcement, and delayed consequences of hair pulling. And this highlights that it's multifaceted. Then we have a cognitive control model that's very much like the CBT model that says that affect regulation, behavioral addiction, and cognitive control are at the core of the difficulties experienced. Moving on to effective dysregulation, it says that effective dysregulation can also play a part in maintaining and developing the hair pulling. And then the stimulus regulation model, grooming type behavior, states that people pull when they are either over or understimulated, and may this be linked to a genetic predisposition to effectively manage internal sensory imbalance and in an external manner. I think that's very often what we see is people will be bored and play with their hair. It kind of leads to something more, a habit that goes into a repetitive behavior. And then, last but not least, the comprehensive model of Trichotillomania just states that grooming type behavior is ideal for reducing or producing stimulation under which the hair pulling falls. And it states that no one model could ever fully explain hair pulling disorder, and that treatment should speak to all various inputs internally and externally. And then it goes on to describe 4 internal modalities that they work with. So all in all, you can see that there's no one one explanation, for trichotillomania. It's very multifaceted. So the why it happens is multifaceted, and thus the treatment is also multifaceted, which we'll talk about a little bit later. So moving on to who. So who gets diagnosed with trichotillomania? It actually gets diagnosed in the whole population. In my study, where I saw participants, I included only adults, but we had a range from people turning 18 that wanted to be part of the study to a participant that was 75 that did the cognitive training treatment. So it's really a lifelong disorder. So if we look at the ratio, it's 10:1 for females versus males, and has been noted in adults with hair pulling disorder. The average age of onset for hair pulling disorder is 12 years. So we very often see it in adolescents and adolescent girls. And what's important to note here is that the age of onset for self-harming behavior is also in adolescence, but it's not the same thing. Hair pulling disorder is not self-harming behavior. It falls under the body focused repetitive behavior. Sorry, there's a lot of words to fall over this morning. So it is not self-harming behavior. The prevalence of hair pulling disorder in a 12-month period has been estimated at between 1 and 2%. So it's prevalent in our society. And like I said previously, we don't see it because it is very rarely the first diagnosis or the first, struggling with my words this morning. It's very seldom the primary diagnosis that someone comes to you for. It often also people go to the hair salon, it gets picked up there, or they go to the GP. They very often think it's a medical problem. And so the people go through various routes before they get to psychiatry and mental health or psychology. Now, what the impact of this is, it really is dire. I'm going to take you through the main themes that I highlighted in my study. And Tony, here you can please just share the link to the thesis. So you'll see when you go to the thesis link that the study was divided into two parts. So there was a statistics part that looked at cognitive training specifically for patients with trichotillomania, and then it looked at the experience of living life with trichotillomania, also the experience of being part of the study, and just kind of qualitative, sitting with the patients or participants at that stage, and just hearing how does hair pulling disorder impact their life. So a few themes were highlighted that I would love to share with you. So first of all, I just want to move this here. Okay, so first of all, they reported about the hair pulling experience. They reported that there are triggers and behaviors that make hair pulling very difficult. That sometimes something bad might happen and it might trigger them to go pull for hours on end. They would talk about the onset. Very often, like I said, and like literature shows, the onset is during adolescence, and it's hard for teenagers. They hide it from parents. They don't want to get scolded. They hide it from their friends. It's so embarrassing, and very often they feel isolated and don't really know what's going on. But we've also seen that onset happens in early adulthood. And very often is linked to a stressor, but often it's also not linked to a stressor. So it's difficult to ascertain because it's a very individual process. Then they spoke about the immediate impact of pulling, that kind of saying to yourself that I'm not going to pull ever again, and then being so disappointed when you go through this behavior. And then the insights. Very often when they start talking to researchers or other clinicians, they gain kind of an insight into what this pulling experience could mean for them. In my study, it was very often participants were self-referred. They heard about it on the radio, they saw it on the website, and then it was kind of a light bulb moment, like, oh my word, there are other people doing this as well. So let me find out a little bit more and let me go speak to someone that actually knows about the disorder. The second section that they spoke about were emotions, of course. So lots of emotions prior to and leading to the pulling. And it just ranged from being bored, being listless and not wanting to do anything, low motivation, to be very anxious and or depressed and feeling very alone and isolated. So, and then the after or during the pulling or because of the pulling, emotions that came out: guilt, shame, embarrassment, anger. So you can imagine how complicated this gets if you don't really have an ability to regulate your emotions and you're sitting with this behavior and you think you're the only one. Relationships definitely get influenced. Now, there's a few relationships that really stood out. Family of origin, that is important. Sometimes they don't want to tell their parents or their family what's going on. The behavior might be modeled. It might be something that they've seen in the family. Very often, parents who pull themselves will do it in secret because they don't want their children to model the behavior. But I mean, children are so perceptive that they sometimes pick it up, even if you think that they haven't seen it before. Then, like I said, the family patterns of body-focused repetitive behaviors. So just to kind of as a side note, the body-focused repetitive behaviors include skin picking, nail biting, any disorder that's focused on the body that you do repetitively. It's kind of that compulsion to do it. So family patterns, learning from siblings to do this behavior can also play a role. And then the role of community, friends, and colleagues. Very often there is this need or this want to pull at work or pull at school, but because you're surrounded by people and you don't necessarily feel safe, you don't do it, and then later when you're home, it's kind of like you need to, you moet inhaal, if I can say it like that. So community of friends that are supportive are so, and non-judgmental are so important. Then the role of the spouse or the partner. Very often partners know and spouses know, but they don't know how to deal with it. And that is also the difficulty. So it won't help to scold, it just makes people feel more ashamed. Then from the parent side, the role of the children. Children can also say, but mom, you're crazy, why are you doing that? So lots of judgment. And also, like I said previously, the role of the child is also, you don't want them to learn your behavior. But children can also be very supportive in monitoring the behavior for their parents. And then the role of the hairstylist. I had a participant that told me that she never ever goes to the hairstylist. She's never been, because from a young age, this was a problem, and she really doesn't feel comfortable to explain to the person what's going on. Another participant said that she goes to one hair salon because the lady is so supportive, and she puts up a screen so that no one else in the hair salon will ask questions about what's going on. So it's actually so interesting to see what people, or who people with hair pulling disorder feel comfortable to engage with and not engage with. Now, moving on to interventions. It is interesting because people feel that they're the only ones doing this behavior. They very often have the most creative self-help attempts, if I can call it like that, to counter this compulsion, or to counter the hair pulling. One example was, I don't know whether you know this fidget cube. It's a little cube. I think you can get it at the China shops or online. So people use this to keep their hands busy. So if they sit in front of the computer or the TV, then their hands are busy. But very often, the one hand will be busy and the other hand will start pulling again. People will wear huge gloves. They will wear beanies on their heads, scarves. It's also not only your head hair. People pull out all the hair on their bodies. So sometimes it's, they pull at places where other people cannot see. So there are many, many, many attempts that people have done to help them counter this. They've taken medication. They wonder about diagnosis. Many have gone for therapy, psychotherapy, maybe more psychodynamic therapy. And very often they would also talk about how frustrating it is that the outcomes are so ineffective. And very often there's not a lot known about hair pulling disorder. I mean, even, I don't know who of my colleagues are here, I cannot see everyone on the screen, but very often people would say, I kind of heard about it in my training, but I don't really know anything about it. So I think it's something where if you don't specifically ask, the person that you are assessing won't necessarily comment on it because they think, it's just me, it's not that serious, my mood is more serious. But if you feel that you cannot go for a swim because you don't want to get your hair wet, because people are going to see bald patches, then it really impacts your life. And then you kind of not living a quality life that you actually want to. So people with hair pulling disorder are excellent at hiding. And if I think about the study, I think there was one lady that came that people could see that, okay, she pulls her hair. Everyone else, and we saw over 40 participants, came into the office and, neatly groomed, well-groomed, makeup. You would actually never say that they hide that secret. And once they show you, it's just like the wheels often just come off because they're so embarrassed and they've hidden the secret for so long that it's really just a release to be able to start talking about it. Okay, then that kind of links to the self. So there are lots of beliefs around the hair pulling disorder for the participant or the patient. So believing that, if I was a stronger person, I could stop this behavior. Believing that, I'm actually not worth it. I'm supposed to to pull my hair. It's I don't cannot get to the word now, but I don't owe myself to look after me. So there's lots of beliefs, lots of core beliefs that come to play here that actually make it really difficult to stop the behavior or to replace it with something else. Then the impact of not being sure what the behavior is, that is an extremely difficult, concept, because if you don't know what it is, how are you going to know how to treat it and where to get help? Then very often we also see that they might have other body-focused repetitive behaviors like skin picking or OCD-like behaviors. It's very often a personality that is very kind of strict on themselves and very, checklisty, if I can call it like that. So, they enjoyed the cognitive training because it that I used with the intervention, because it felt like they are accomplishing something. And then lastly, asking what life would be like without hair pulling disorder sometimes floored them because they've never imagined that could even happen. So I think that was interesting for me. So I think there very often comes in the kind of motivational interviewing modality where, yes, this is a behavior that has an impact on your life, and how would it be different if you didn't do it? And very often you kind of get that resistance because it has a function. Right. So moving on to treatment, I think the most important thing is that you need to address all the symptoms of hair pulling disorder. But you also need to aim to improve the associated distress and impairment in work, family, social relationships, self-esteem, and health. This is something that really does impact, the family. It's not an addiction per se, but I always feel that it has a lot of the underpinnings of an addiction, of a behavior that cannot be stopped, and very closely linked to the emotions that goes with addiction, and that feeling of not being able to control the behavior. So literature shows that behavior therapy is quite effective. Habit reversal therapy is a type of CBT that's effective. More recently, they started enhancing the CBT, like the HRT, with dialectical behavior therapy or acceptance and commitment therapy, that are therapies that very much focuses on emotional regulation, acceptance of behaviors, not judgment. So the kind of the new wave is being brought into and matched with the old wave. I think therapists will know what I'm talking about here. But it really focuses on looking at the behavior in a very non-judgmental manner, validating that that's what you need to do and that's what you are doing, but also challenging in a very soft manner that life can be better without this behavior, and what can we do to help you regulate your emotional state, and also get other behaviors that isn't as damaging, that is more appropriate and that will lead to a better quality of life. And then very often, as I think most things in psychology and psychiatry, it is helpful to pair the psychotherapy with pharmacotherapy. Up to date, there hasn't really been any pharmacotherapy that is like first line treatment. So first line treatment is your psychotherapy, and sometimes with a little bit of add-on to maybe work with the anxiety symptoms or depressive symptoms, because that does play a role in trichotillomania. And then interesting is the NAC. There's a lot of studies being done on NAC and the impact that might have on treating the symptoms of all the body-focused repetitive behaviors. But the studies are small, and we still have to keep our eyes on that. Right. So kind of just moving to just concluding the treatment section is, so at the end of the day, it's important to, once again, holistic. You have to treat the whole person. So talk therapy, the therapies that I mentioned, plus medication, that might be, the the thing that you need to look at for effective treatment. And then also, like I mentioned earlier, the new kid on the block, cognitive training. It's a little bit outside the scope of this talk this morning, but when we did working memory cognitive training to kind of strengthen the brain pathways that focuses on your ability to counteract certain behaviors. And that seemed to have worked well. The study was small. Like I said, we had about 40 participants, half in the placebo group and the other half in the cognitive training group. They did everything online, everything was matched, and we did see significant statistical benefit from doing the cognitive training. And what's nice about that is you don't have to talk about your childhood. You don't have to go and go very deep. It's practical, and it can be matched with other treatment modalities as well. So I think, all in all, I'm excited for what may be ahead, but as with the NAC, the jury is still out. Okay, then I'll just like to conclude with the following quote. Mental health problems don't define who we are. They are something you experience. You walk in the rain, you feel the rain, but importantly, you are not the rain. And I thought that, I'm getting goosebumps as I'm sitting here, because I see so many people that feel that their diagnosis is their identity. And if you feel that you are your diagnosis, it's very, very difficult to take a step back and to manage that, because you feel that like you're managing yourself all the time. And I think that's something that came out with a hair pulling disorder. And I often say to my patients, you are not bipolar, you are not borderline, you are not a hair pulling disorder. You are a patient that needs to learn how to manage the X, Y, and Z. So yeah, I think that was important, and also with all the rain that we had in Cape Town, I also thought that that it was quite fitting, just to maybe share that with your loved ones as well. Right, and then just lastly, I'd like to share with you some nice resources. The TLC Foundation for Body Focused Repetitive Behaviors. They're in the US. Amazing website. They just do wonderful work and so much information. So if you ever are wondering about hair pulling disorder or body focused repetitive behaviors, they are kind of your one-stop shop for information. And then Trichstop is a nice website. Stoppulling.com is a nice website. The Mental Health Information Center, Janine Roos, there links with the hair pulling disorder and OCD studies that's happening at the MRC. So if you have any questions, you want to refer your patients, you yourself might want to get involved with the research happening there, you can just contact them and ask for a referral to Professor Lochner. She was my study supervisor, brilliant with OCD, can really recommend her. And then last but not least, because I feel everything is about the experience of what we struggle with and what we need to deal with. The YouTube link that I shared at the bottom of the screen is it's a girl called Becky, and when she was an adolescent, she started pulling, and she's been YouTubing and uploading videos and tips, and just her experience of going through Trichotillomania and living with that. She really is an awesome ambassador, and someone that I sit with adolescents that I see, and I play the videos, even adults, because there's just like this breath that they take of, I'm not alone, and I can beat this, and sometimes there will be a relapse, and sometimes I'll do better. So yeah, that's a really nice resource to share. So yeah, that is my story on hair pulling disorder for this morning. Thank you for everyone for joining.
Thank you, Derine. That was a lot of information in a short amount of time. No, it's great. It's wonderful. And I think that those resources, it's something really great for us to follow up on and to have a look. I think it's a very broad topic with a lot of information. You did a great job of condensing it and making it understandable. So thank you very much for that. We do have a question in the chat box. We have a few minutes for questions. Francois said, would like to know about some of the comorbid psych disorders. Did many have tics or Tourette syndrome?
I think that's interesting. In the study that I did, that probably would have been an exclusion criteria, and I'm not so sure about with initial screening how many was excluded because of that, but I would imagine that it would kind of be part and parcel, that it might be part of the kind of the group of that diagnosis that we see. So yes, I would imagine, but like I said, I cannot really comment if I link it to the study because of the exclusion criteria.
Okay, thank you, Derine. Is there anybody else who has any questions? They'd like to unmute themselves and pop a question. Oh, okay. There is another one in the chat box. What was the qualitative method you used in your study?
Okay, so we didn't delve too deep into the qualitative. So we really just did a, the, what do they call it? Theme analysis, thematic analysis. Feels like very long ago. Yeah, if you asked me 2 years ago, I would have given you all the lowdown of all the theory, but yeah, we just did a thematic analysis. I just kind of took out the main themes that came up, all the time. And I think maybe, in the next slide, if there wasn't so many stats involved, I would actually like to delve a little bit deeper in the information that we have, because I really enjoyed that part of the research.
Okay, thank you. Derine, I had a question. I wanted to know if you guys looked at, if there's research about, so for example, I know that with OCD, there's an immediate feeling of relief for some people, or it's a control. If there was some research or about, like, what is it an immediate good feeling, or does it default to shame? It's not going to be the same for everyone, but if there's some sort of theory around that.
Yeah, I think like everything, Tony, there are so many theories, and it's really it's so individually specific. I mean, some people, they will pull and they don't even realize. And then, like they're sitting watching a webinar, see, no one's pulling today, but, they might sit and play with a hair pull, and then when they see there's lots of hair lying on the ground. So some patients will say, there's like emotion and, it's just overwhelming, and some really, they just pull. Okay. So yeah, I think it's interesting. I think if you Google that, you'll get lots of examples.
Okay, we have 6 minutes and we have 3 more questions. So let's see if we can get through that.
Okay.
All right, my son is 11, autistic, and pulls hair. Is this common? Besides medication, what is appropriate therapy?
Yeah, I think, it's difficult, because then it might not be hair pulling disorder. It might be, like a stereotypical behavior of autism and linked to that. It might be anxiety. I think with someone that's on the autism spectrum, a more behavioral approach might be more beneficial. Maybe if he has a tutor, then maybe they could work on that. I think it's multifaceted.
Okay.
I don't know whether I'm answering the question. Oh, Hannah, hi.
Hello, Dr. Derine. My brother, when he was little, he used to do this twiddling on the
crown
here on top of his head, yes. And then he used to pull and also do like a kind of flicking on the hair. I realize now it was more of a self-soothing than a trigger, even though some of the hair did come out. But he was never treated. That was quite a number of years ago. My daughter has skin picking. So she has quite high anxiety levels. And our psychiatrist, Dr. Carew, prescribed It's a pill that's used for menopausal women, and it's found to have a oh gosh, I forget the name right now. It's found to have an effect with people who have these kind of skin picking, hair pulling disorders, and it has actually alleviated to some degree with the SSRI as well.
Yeah. So I think what you're also saying is that, you know, the different, everything needs to come together. It's not just a one size fits all.
That's right. And like you say, also sometimes when people are conscious of the picking or the pulling, and then most times she won't be conscious, she'll just be picking, and then later I'll say to her, oh, you're bleeding, or oh, you've been picking, you know, are you feeling a little stressed, or, you know, and she said, no, I didn't realize I was doing it. So yes, I can totally understand when you say the conscious versus the unconscious.
I think sometimes, like your brother, it started as a self-soothing behavior, and then we must remember that any behavior that we do is strengthening a brain pathway. So the more you do this, the more strengthened that neural pathway is, and so that's difficult to break.
He seemed to have it as a child, though, and then by the time he reached teenagehood, where your research shows that it usually starts in the teenagehood, the proper hair pulling disorder, his abated at that time. So that's why I say I think it was a self-soothing. But he also didn't seem to feel the pain. We'd say to him, you know, but it's bald there, you know, you're not, no, it doesn't feel sore. So it's also an unconscious kind of.
I mean, children can outgrow it, and I think as they learn to soothe themselves in other ways, versus whether it's sports, whether it's engaging with friends, so it's not necessarily that it will lead to hair pulling disorder.
All right, we are running out of time. Derine, I wanted to ask a question. I've made a note of the 3 questions that we have left. Do you think I can contact you and we can just address it in a follow-up email? You can just give us like a little bit of information. So to the people whose questions we didn't get to, I'll pop.
Sorry, guys.
I think it's a very vast topic. So we can pop that in a follow-up email, and then I'll also include the resources that Derine's mentioned in her talk. All right, so I think we're going to have to end off. We have less than a minute. Thank you very much, Derine. Your study sounds fascinating, and this was really great. And hopefully we'll have some more webinars coming up if we can rope you in. And thanks everyone. And everything will be available on YouTube, and you can just have a look out for the follow-up email with all the resources. All right.
Thank you, Tony.
Thanks.
Bye, everybody. Have a good day.